My name is Dr. Sarah Cole, orthopaedic surgeon based in Cairns in Far North, Queensland. It's my great pleasure to introduce Mignon Prinsloo, who is an occupational therapist with interest in hands. And she's going to talk to us obviously about managing hand injury wounds, and then we'll have some questions. Thank you. Take it away.
Thank you. So, as Dr. Cole said, we're going to be talking about managing hand injury wounds. Wound care is such a big area because there are so many different types of wounds. So the thing is, when it comes to a hand wound, I find that sometimes some GPs or nurses don't know what to do with them because they have more experience with other types of more chronic wounds like leg wounds and stuff. But so this is just to kind of make it a bit easier, just kind of what we think people who are working in hand therapy, just so that we can have the best outcome for our patients. So about me, I am an occupational therapist and I work at Cairns Occupational Therapy. So my main caseload is hand therapy, and I also do work ergonomics, which I enjoy as I see it as a bit of an injury prevention. But I'm completing my hand therapy accreditation with the Australian Hand Therapy Association at the moment, which is a bit of a process, but it's been really good. So when looking at wounds, I like looking at the skin first and what the skin does. So skin has a few different functions. So it holds fluid, the regulation, temperature control, it has sensation, it's metabolism, and also communication as well. So with our skin layers, so there's a few different parts of our skin layers. We have our epidermis, that barrier. It also controls water loss, protects our bodies, and of course from the UV, bacteria, and other allergens. We have our dermis, contains our hair follicles, blood vessels, cutaneous gland, sebaceous glands, and also helps with maintaining our moisture balance. And then we have our subcutaneous tissue, so it provides insulation and padding, and the thickness depends on part of the body. So our hand would have thicker skin than the back of our hand, and it also depends on the age of the person. So we have some changes when we get older. So there are factors that impact our skin integrity. So we've got damage to the dermis. So dermis can have cracking from dehydration, and this impacts the ability to hold moisture. We have age, so the collagen and elastin fibers, they reduce, and then the dermis becomes thinner and increases the risk for tears. And we see that a lot more in terms of transferring people when they're older in like in aged care facilities, for example, but you can get tears really easily on skin from removing dressings incorrectly. And also there's slow healing and less sebum production. pH levels, so we want to maintain the skin mantle as well, which helps keep bacteria levels low. If disturbed skin is vulnerable, it's to damage and infection as well. And then moisture. We don't want our skin to be too moist, and we don't want it to be too dry, as it damages the dermis. So we want to maintain a good wound environment for healing, especially in Cairns where we typically are more moist and dry, and wounds get soggy very quickly. So, inhibitors for wound healing. So, reduced vascularity, we've got poor nutrition, infection, diabetes, smoking, and I've also put down nicotine use because there's now multiple ways to have nicotine. And I find that when I'm working with someone, I always ask them if they smoke, but then if they say yes, I ask them, or I'll probe more into the question rather than if it's a yes or no to tobacco. I will ask them exactly what they're using. If it's vaping, because I find they probably have more nicotine than a smoker, but also there are other oral nicotine products like that's called Zins, so they're like a mouth patch, which is constant nicotine while it's in their mouth, so that's for a few hours. Also other people with immunosuppression, and there's other drug therapies, some people with poor psychological state, and also age. So age makes a big difference on our healing as well. And here are some poorly healed wounds from mostly smoking. So, and they're only really at the start of closing once they started reducing. When I talk to my patients about smoking, I don't tell them you must stop, because otherwise I can damage my therapeutic relationship with them. I tell them it's like, I can understand, it's a difficult thing to stop, but we need to try and reduce. And I'll just keep reminding them as we go along once the wound doesn't heal, because then they start getting annoyed that they can't shower properly because it's in a bag for a while. And then also I like going over the clinical importance of diagnosing infection. So with infection, myself as a clinician, I rely on clinical characteristics. I'm not able to order swabs. So, and I found this lovely stat of 98% of the time, that's what we use. But then we have also patient-reported symptoms of them being unwell, but then also root cultures, they come in to let us know exactly which bacteria is present, so we need to start with any antibiotics. And again, this is a wound that, this is after it's been debrided, so, and that's only how I can get it to look like that. Anyway, so for signs of infection, purulent exudate, that's the first thing that really stands out. If we have infection, you're like, oh my goodness, yeah, this isn't looking good. So it's thick, it's opaque, tan, yellow, green, or brown. And then we've also got hypergranulation tissue. So if there is hypergranulation, it doesn't always mean it's infected, but typically it can give us some ideas that just the healing isn't as optimal, because the body is just trying to create too much granulation tissue, and so the skin can't grow over it because it's blocking it. And so we need to try and get that to calm down, but if there's infection happening, it's not going to listen well to that treatment. Abnormal foul odour, it smells pretty badly if you get a wound that's not happy. And it's just byproduct of the bacteria. We have increasing temperature, so it's just a sign of inflammation. You'll see redness as well with erythema, and also it depends on how deep or how much the infection is, but it can spread if we're not addressing it properly, which is then risk of that infection getting into other structures like the tendon sheath or the bone, which is very bad. So we want to address the wound infection just so it doesn't have more complications moving forward. And then there's induration and edema as well. So we don't want thickening of the soft tissue, and the swelling will limit how well the skin edges close, because if there's just so much pressure on it, it's just going to be fighting to close, and it's just as your body has to work harder, which will then lead to more scarring as well. So that back here, this is like a good example of the induration on that, the dorsal side of that hand, just because that wound was probably open for a good 9 weeks. So it just is not ideal. So with our infection classifications, we've got clean. So we have our uninfected operative wounds. So that's what we get from the cold, lovely, nice and clean. They look pretty good. Nothing has happened in that time. And then we've got some clean contaminated. So that is more for other parts of the body. So, involving our respiratory and genitals or pulmonary or urinary tracts. They're just areas of our body that typically has more bacteria anyway. Then we have contaminated, so it's an open, fresh, accidental wound. And then we have dirty and infected. So these are all traumatic wounds that have, clinical signs of infection as well. Or there's a fissura. So hand wounds and injury healing time frames. So it just depends on the structure, but then the location of the hand, pattern, and also the complexity of the injury depends what's happened there, but also the individual patient and treatment factors. So we're thinking about what's our risk for infection and like what can make prolonged wound care. That's kind of where that comes in. But I found this statement, and it's like all hand wounds have the potential to limit function, and it's so important to remember that because it can really, it can limit our flexion or extension or a sensation, or it can be very hypersensitive. So we don't want that to happen. That's a complication we're trying to avoid. So when we're looking at healing timeframes, I also like to look at other structures involved. If someone has a hand wound and they're seeing me, they typically have another injured structure. So I also like thinking about, okay, the skin should take at least up to 14 days to close. So if we are, but also if we're treating a tendon injury, we have to keep in mind that tendon's going to take at least 6 weeks to get about 50% of its strength. But we also need to keep in mind about adhesions and scarring and all of that going on. So, but with our dermis and epidermis, we want to close at 14 days. Once it starts going past that point, your risk of scarring is significantly higher, or more complex scars. And then we also then have our arteries and veins. If they've been repaired for at least 3 weeks, so we want to make sure we're not tensioning them too much and just not breaking that repair. With our nerves, same thing, 3 weeks as well, but we really want to keep in mind that they heal slowly, because that can, if there is nerve injury as well, that wound might be more sensitive or hypersensitive, and so then completing wound care is not as comfortable as well. So you start feeling really bad when that's been happening. But it needs to be done, otherwise you just can't have a good clean wound. And then for bones, up to 4 to 8 weeks, depending where it is then. And then our tendons, and like I said, we have 50% of our strength by week 6, but we need to remember that with our tendons, we have adhesions that form, that they're strong, they're really strong around 10 days, so we just want to keep that in mind. Okay. So, things that we want to consider. So we need to consider the primary injury, like I said before. So we want quick wound closure, especially. I say this for tendons in mind, but especially for tendons, just because adhesion is so difficult to treat once it gets in. And typically the wounds that I've had that's taken the longest are tendon repairs, but they're smokers. So we want to try and have them close a bit easier, because then that movement's so much more comfortable as well when we're doing the protocol, or working for our protocol. And typically we've adjusted it just so if they are smoking, the tendon's going to heal slower as well. We want to be careful not to have any rupturing or attenuation. So other thing we want to think about wound care is also maintaining safe positioning. So each condition typically has its own position it needs to be kept in. So, but I like using tendons as an example, but we want to maintain that positive position that they would be in the splint, just so that we aren't accidentally, breaking that position and then at risk of rupturing. And then we want to have movement-friendly dressings as well. We want it to be as light as possible. We don't want it bulky if it doesn't need to be. So then typically our therapy involves movement, so if it's appropriate for that condition. So we want it to feel easy to move and not restrictive, because some patients feel like if the dressing is too restrictive, first of all, it's putting too much tension on whatever is the injury, but they're more likely not to do their exercises because it just doesn't feel right, and they're scared they're going to break something, even if it's something that's stable, like an orthopone. So there's a little example of we want to have optimal dressings, but also something that can address edema as well. So typically we would have something like, say it's a finger injury, we'll have a dressing, light foam dressing underneath, and then we'll secure it with handy gauze cohesive. And the thing with handy gauze cohesive, it moves with you. It will feel there's a little bit of pressure when you're moving into a fist, but you should be able to complete it. If you can't, it's probably the edema that's blocking you from movement rather than the compression. And we want to avoid bulky dressing. So these two photos aren't mine. But we don't want to, we want to have our dressing nice and comfortable. That's going to fall off. And then once dressing falls off, people just leave their dressings uncovered. So we don't want that to happen, because then again our risk of infection is a lot higher, and also de-seeing. The only things we don't want it to do. So for suture removal, I like my sutures to be removed around the 10 to 14 day mark. When they're done earlier, it just makes the scarring a lot more, and it can be a bit frustrating. So, but the removal is obviously dependent on some factors of like what the tension was at the time of closure. It just depends on like how much skin you actually really have available to come over, or if you've had to take some off, if it's a revision, whatever the surgery is. We want to know if there's subcutaneous sutures present, because then that means there's just a bit more strength there. So we know it should be fine. Age of the patient and the medical history, so if they have diabetes, it might heal a bit slower. And then also if there's any medications that can impact on their wound healing as well. But then there are times where you have to take sutures out because it's the only time we have with them, especially if they're traveling from the table ends and they're trying to do all of their appointments on the one day. So what I like doing is using Cerastrips to reinforce that wound just to stop it from de-hissing, and then covering it as well. Because I think some people think that once the sutures are out, it's a fully healed wound, but we still technically open from where the sutures have come through. So we just want to give it a few days just to allow that to close up properly too. So with our wound care product categories, there are quite a lot. So there's so many different types of wound care products that you can come across. They do a whole lot of different stuff. Some things on this list we don't use because we can't keep everything. And most GP practices, they have a very limited selection of wound care products. We would have more than, I would say, most GP clinics, just because we do need to have a bit more of a specialised approach to our wounds. But we try to, these are just the kind of the categories. So utilising barrier creams to protect skin, especially for those at risk of skin tears. Also, I've noticed with with the heat, when it's summertime, and if they're in a very thick splint and they're bandaged as well for edema management, some people's skin really reacts to that sweat. So if I've noticed that happening, I'll put a barrier cream on to just try and give a bit of protection. Those people are also then at higher risk for wanting to take their dressings off and their splint off because they're just so uncomfortable in it, especially if you have not going to see them for a week or a few days even. It's just quite irritating. So then there's the semi-permeable films, we have hydrocolloids, which we really like if it's a wound that's not oozing too much. We've got hydrogels. We don't really need to use those because we typically have a lot of moisture up here, but that would be used if we have an exposed tendon. So just to make sure that tendon stays nice and hydrated. Calcium allogenates, foams, there's so many different types of foam dressings out there. Gelling fibers, a whole lot of different things that I'm sure. So the way I like looking at wound products are like what they do and what we want them to do. So different things like an atraumatic dressing, that would be a nice soft silicone. So that's our Methalexes. So Metalex Light, I don't know the ones that you use post-op, but they typically come off really easily. So that is just comfortable, and then they just don't stick. I try and avoid ones that stick too firmly.
The newer type that we probably see more now and are much more affordable is the Super Soul P sensitive.
Yes, the thin ones.
Thin.
Yeah.
Order.
So there's a whole lot of
light.
Anything light in the name. Because some of them have a bit of a thicker foam, which is great if they're having a lot of extra day. You want to get that, that moisture off the skin and have it stay in the dressing and keep making it really moist. We want to offer sometimes protection. So This is more for when the wound could be kind of closed, but it's very fragile. It could just open. So this is where the hydrocolloids come in that we like to use, especially if it's something that has no use, because in cans you will just macerate that wound right away. Or there's some films like an off-site film, but they get quite sweaty pretty quickly too. And yeah, we also then have some of our art dressings as well. So for debridement, so this is when some wounds are so sloppy, but to debride them manually, sometimes you can get a good amount off, but sometimes it just doesn't want to move. So this is where some of these dressings, it's like a primary dressing and then we'll have a secondary dressing on top. It will do the job for you, and the next time you see them a few days later, it will have mostly, basically, it's kind of like eating it up. It just kind of helps with that process, and it's a lot more comfortable than removing it manually. But at the moment, the one we like using is being discontinued. So we probably have to try and look for a new one. But it just makes it around. Yeah, there's plenty of different brands out there. But you can use hydrogels. I've used this one dressing that's called Mignon. It's a hypertonic dressing, and it's like, and what it does is it just helps to draw out the moisture because it's got a lot of salt in it. Mignon. I've used it a few times. It's not as good as the Super Salt G that we use, but it's a good cheap option. You can also use it for hypergranulation as well, especially if the area is too big for silver nitrate. And then we've got our wound hydration and retention, so that's hydrogels and hypercolloids, but we wouldn't really do that in cans. Exudate management, so we want to really absorb, but that's where our foams come in that we would use. So typically a thicker foam, especially if it's a palm wound, they get so macerated so quickly, especially those structures. And then we've got our antimicrobial, so these are typically quite expensive dressings. We try and avoid these if we don't have to go there, but if they need it, then we'll put it on. But this is like the silver dressings. Another thing that the Mignon can do, it can replace silver. So the Mignon, for example, I think is $6 for a dressing. It's a lot more economical than a $60 dressing. But I haven't used the Mignon for antimicrobial option yet. So we'll see when that comes through. Other thing that we love using is microdicin. I'm sure we've mentioned this before. So microdicin is a fantastic wound cleaner. It can help debride as well. It reduces biofilm, and the bacteria burden, and it helps oxygenate the wound. It also is very time efficient in terms of softening like really sticky slough, because in private practice we are trying to make the most of the time we have with the person and get more therapy going. So with saline, you're just waiting and waiting and waiting for it to just soften, whereas this is, we'll try and have it soak for 10 minutes, but you don't even need that long. It just depends on what the wound is doing. And we'll pour it into some pores and then just like place it on the hand just to kind of sit there. Sometimes if we have like a fingertip injury, if we have one of those sterile packs with the little tray, we'll pour some in there and then you can soak it. Or with the gauze packets, you don't really need much depth. You can just pour it on the plastic side with the gauze, and then you can kind of just let it sit in there while you're talking to them, seeing how they're going, and catching up. And Pontostan is also another option, but we don't use Pontostan, we like microdicin. It does the same thing. It's a living. So we have our edema management. So edema is, like I mentioned before, it's really important to talk about, because this can really impact our range of motion, especially when we need to get someone moving. With back to tendons, if someone's tendon repair isn't moving, or if we're not able to even passively get them to a half fist, it's not the tendon that's at fault, it's the edema. That's what's really blocking it. So if we can get that to stay down, it's a lot easier to rehab process, but then again, that wound is just not having so much pressure on it. But also, it can also then lead to a stiff hand as well. Over Christmas time, typically Christmas time is when we see the most stiff hands, just because there's services that aren't running and people aren't going to seek help with their hand injury as quickly as they typically would. And so it just prolongs that therapy so much, and it's not a fun process to go through if you don't have much movement of your hand at all. So the other thing to keep in mind is that we don't have any lymph nodes in our hands. The last ones are in our elbow. So if we're not moving well, or we're not able to move because of, let's say, destruction, we don't have much way of that fluid to leave. So it's like our muscles act like a pump in getting them to move, but we want to then have some form of compression just to help get it out. The longer the hand stays swollen or has more edema in it, the harder it is for it to move on, because it starts kind of drying down. We have a saying in our office, at first it's like a river, it flows and comes and goes, but then once it starts staying there for a while, it gets boggy and it's thick and it gets fibrotic, and it's just a lot harder to manage. So, and also it will make your hand a lot more comfortable if you're having pain. You can just sometimes see it move out once people start elevating it, and they're like, oh, that feels so much better.
It's not going to stay out.
It's not going to stay out. No.
That's one of the things we often kind of need to come back to. It has to have compression.
Yeah. So that just makes it so much easier as well. So some of the products that we use. So we love handy gauze. Handy gauze cohesive is products that probably used the most in a post-op appointment. It's nice and gentle, really. So especially when something you don't want to have too much compression on. Downside is you need to be trained to put this on. It's so hard to put on yourself. I can do a few fingers on my own, but I wouldn't be able to do a whole bandage on myself. So try, and then but it's ideal for if we need to do a whole hand bandage to the forearm with, and then finish it off with the thicker version. But then other thing is it gets dirty quite quickly, so it is a good indication if someone's actually listening to you and resting. You can tell if they've been in the shed very quickly, it's all black. But it does start falling off if they're doing too much extracurricular activities and not really therapy as much. But it's quite a nice product. There's just some outfits. The other one that I like using is COVID pin strap. So this is something that we would use a few weeks after surgery, but it's easy for the patient to put it on themselves. I don't have any with me, but it's thicker than that material, and when you apply it and you lose a bit of something, it will kind of, it won't stretch, the stretch will go down, whereas with the handy gauze, it will stay at the but it was just the amount of tension you put it at, it will stay. It's not going to scratch down on itself. Which is also why we like using handy gauze for a tendon repair post-op, just because then we know it's not putting too much pressure on it. And then the Coban will give someone a roll. If it's a finger especially, we can just get them to cut a piece and then they can pinch it themselves and then fold it over. And then the other option is compression gloves. So it depends on how far along they are with their wound, but it's very convenient because the patient can take it on and off themselves. You typically need 2 pairs just so they can wash it, because it does get a bit sweaty up here in hands and you can smell it pretty quick. But it doesn't work well with finger wounds or wounds that are quite high up on the hand, just because they will roll on and off when you're pulling the glove off. So it's better for those kind of more wrist wounds.
And they need to be sized.
Yeah, they need to be sized.
Measure their fit.
So the ones we like are the Norco ones. They're great for someone who can't move too much, because they're nice and soft and they slip on really well. And then we have ones that have a bit firmer compression for when it's appropriate to move them on. Oh, oops, there's something, sorry. Okay. The other thing is post-operative elevation. So this is to, when we've had that surgery right away, we have so much swelling coming through just because, the body's gone through this trauma. So we really want to prioritize elevation, but a lot of times I ask patients like, are you elevating? And they're like, yes, and they do this on the table. And then they just sit like this on the TV. But the problem is that it's not actually leaving the arm. So, and then it can, even though we have our lymph nodes here, it gets stuck. So we want to allow it to move on. So I've been making a point recently, because I've noticed I hadn't done it as much, but I've been making a point of telling them to really elevate the arm, have the hand higher than the elbow and the elbow higher than the shoulder, using pillows. Especially if they have a bad shoulder, then they might find it a bit uncomfortable, so you kind of got to try and work with them a bit and get that positioning right, and like not using a sling. So we just want to have it nice and comfortable. Especially that first 2 weeks, it makes a big difference. After that, people stop doing it as much, but the edema isn't changing so quickly like it does in that first week. And then we want the edema to leave, go through the lymph nodes, go back to the heart. People also, like, they start rubbing their hands and they're like, oh, because it feels better moving that fluid on. We just want to make sure they're not pushing it further into the hand. So I always just say, like, just kind of, stroking it back towards us like a cat, whatever. People typically say they like cats quickly, yes or no? If you say that, but we want to just have it move on, and typically it will feel quite nice. So that's scar management. So it's a good synthesis of the balance of synthesis and degradation. That's how we can get a good scar. So there are so many different types of scars. We've got immature scars, so that's what we see in that first bit, the nice and pink, that can change. Then we've got more of our mature scars, so this is when they get more white, and they're less likely to have as many big changes. So some people will come in and they're like, I've got this scar from 10 years ago. Will it make much of a difference if I did this massage that we're doing for a newer immature scar? And probably not as much, but you can try. Okay, so here we go. Other ones are, we've got our linear hypertrophic, and then we've got our widespread hypertrophic. So that's more for burns, and then we've got our keloids. So with our goal for scars, we want to have our wound heal quickly, and then detension it. We don't want too much tension on the wound. So even though if our wound is closed, that's also, we want to make sure we're still maintaining our edema management. So we don't have so much, if there's a lot of swelling, you still don't want that to stretch the scar and then create more of a hypertrophic scarring. So with this bloke here, this wound took a while to close, and so it's hard to see, but it's really thick. You can just feel the scar all the way up that hand. So I get a lot of confusion with patients and sometimes GPs about what is hypertrophic and what's a keloid. So this bloke here, he was referred as a keloid scar after a distal biceps repair. And I didn't do his rehab in terms of biceps, but he was referred more for scar management, and it was very thick. I'm glad it wasn't a keloid, just because then I know we can make a good difference. But yeah, that's just something that I tend to see of a lot of GPs referring for keloid scarring, but it really isn't. So it's just good for the patient. But yeah, we can make a good difference with hypertrophic scarring. So this was, lots and lots of massage and silicone wearing as well. And it just was able to just feel a lot more comfortable with that movement. The range was better just because it wasn't contracting as much.
Just the big difference between the keloid and the hypertrophic being that the hypertrophic is raised and thickened, and within the margins of the scar, and the keloid is raised and thickened and extends beyond the margin of the scar. I don't have any photos of keloids on hands. I don't think they're as common on the hand, but I found this shoulder. Yeah. So
tummies as well, and the ears.
Mm.
Lots of ears with piercings not going well. But yeah, so that's typically as well like what we would difference. But it makes sense if you're not sure what the difference is. They do sometimes look similar, but also people are always so worried about keloid scarring. So we do want them to come in if they're worried that they might have something, but then we can also help them with a hypertrophic scar. So scar management options. So I like reminding our patients that we are like an orange. So we have fascia, we have layers all around us. So we've got our skin, like our orange. And then we have, our muscles have layers around them, our tendons have layers around them to protect them, and then we've got the pulp, right? So the scar wants to hold on to all of those layers. It's all big mess of cobwebs. And so people find that when they move, they're like, I can feel the scar, and like it's an uncomfortable feeling because it feels gross sometimes. I've experienced it, I don't like it. But reminding them that everything has its own little protection, and like that scar's just holding it all together, it just helps to explain it a bit better. I learned that at a course, and this isn't been really talking about it, people have been understanding it quite well. But another thing I talk about is cobwebs. It's just cobwebs, and we want to really get those cobwebs to work better with the skin. So then we have just so that the scar can just play better. But it will always be a scar. We can't get it to become skin. So I always just remind them about that, just in case they just misunderstand. But you know, we want to. Our goal is to prevent adhesion, especially on our tendons or even adhesion onto the bone. And then the skin is then it limits that range of motion. So in terms of treatment options, massage is one of my favourite things to do because it works really well. But the thing with the massage is it needs to be deep enough. Some people are really scared to touch their scars. First of all, it might be uncomfortable or hypersensitive, or they're worried that they're gonna break it somehow. Especially after we would have told them like, yep, it's ready to start. We're confident that it's fine. So I will always really make sure I demonstrate to them how to do it and check throughout the treatment that they're doing it properly. Just so then we have the scar that we're making the most of that good healing time, and that it can regenerate, or we can reorganize all those scars, scar cells and collagen to work better with the skin. Another thing that I like to use is non-slip mat, especially for some, because if we want to move the different layers, where our orange are moving all the different segments, if you need to put more pressure down, and so then if someone's a bit more sensitive or they're scared to do it, the non-slip mat is a really good way of holding onto that skin and that scar without needing to put as much pressure down. So it just makes people feel a bit more comfortable, but also it's just easier. And then you can pick up the skin a lot better and move it in all different directions that we explain to people and all that. But we want to, sometimes we just also need to be careful of what's underlying that scar. Just if there is a fragile repair underneath it, we don't want to be too mean to it. So we need to find that good balance of, moving the scar enough so we can get those adhesions to settle, but not being abusive towards our injury. So another thing that we can do is scar taping. I've been doing this a lot more recently, and it works quite well. We can use micropore, we can use Hyperfix, but just a detensioned piece of tape on that scar, and it just helps it to maintain, to stay flat, but also takes a bit of the skin edge tension off it as well while it's healing. So we've been really encouraged to do that through the Australian Hand Therapy Association, I've noticed, and so I've been doing it a lot more, and it's been having good outcomes. Other thing that we want to do is we want to moisturise our scars. Scars are so dry, and when they're dry, they don't work well with the skin. So I always encourage people to moisturise. The golden question is what to use, or people ask about bio oil, and what I tell people is we want something that's plant-based. So basically not petroleum-based, so like a Vaseline, it's not going to do anything, it's just going to sit on top of the skin. So anything other than that, and I think pseudo-cream might have petroleum in it as well, so avoiding pseudo-cream. And just so we can get good hydration to it. And we want to do it regularly because you'll notice that it will dry out a lot quicker. So applying that throughout the day.
That's the original massage is done, dry skin, on dry skin, no moisturiser.
Yeah. So, but some people find more comfort in doing it with moisturiser, but then I say it makes sense because you're not moving as much because you're just sliding off. So, but if they're not doing any at all, but they do some with moisturiser, you kind of pick your battles because then you can get their confidence more up, and so then they might feel more confident not to use a moisturiser first. But that's what we constantly want to check in and see how they're doing it. And then we've got silicone. So silicone is, I love silicone, but you need to use it properly. And it's not, I'll go to the next slide because I'll talk about it more. But it doesn't replace massage. So some people think that's all they need to do, but the thing is you still have those adhesions, you still have that thickness, you're still holding on to everything. So, but with silicone, people always wonder, like, what does it do? So it basically stops epidermal water loss, and so it's really creating a good moist environment. We've got increases oxygen tension and by inhibiting hyperoxia from the signal tissues. It's accelerating tissue remodeling, and also we've got the tension effect of having something on top. So that's what our tape would be doing. But the wound must be fully closed. If you think that it might still be open, do not put it on. You're just going to macerate that wound right away, and then you're going to have an angry patient. But also then your risk for infection is so much more again because it will prolong that wound being opened.
Maybe I'll use a wound care product that has silicone in it.
Yeah, so that's where your lenses will come in.
Specifically, wound care dressing.
So, anyway, but in terms of then, when we're using our silicone, even though I just talked about moisturising, we don't want to have moisturiser on our skin before we apply silicone. So I always tell people, if you know you put some on for that day, wash your hands just so you know it's clear, because it can interact with the silicone. You don't want it to break down in some way. We don't want your skin to have a reaction. So it's just easier to know that your skin's clean and we won't have interaction there. We want to discontinue use if there is any interaction. Sometimes I find that if we're using gel sheeting, which I'll go into in a moment, you have to wash it to keep it clean. If it's on the dirtier side and your skin's getting irritated, it's because the silicone's dirty. It's not really the silicone reacting with your skin. So that's something to keep in mind. But if you're really not sure, talking to a therapist, and then we can problem solve. But yeah, it doesn't replace massage, but it's a great tool to use with it. So with silicone products, we got the gel sheeting. It's easy to apply, but you need to fixate it with tubing grip or hyperfix, or you can use micropore. It just won't stay on its own, and it can be bulky. So especially for during the day. So typically, if I give someone gel sheeting, it would be more for a nighttime application, or if it is on during the day. So that distal biceps tendon repair, he had the gel sheeting on, but because we had tubing grip, we could have it on most of the day. So it wasn't like on the hands, but easier. My next favourite thing that we started using in the last, I would say, 6 months is silicone tape. So this is the best of both worlds of taping and silicone. It's really thin, it's comfortable. You can wear one piece for a few days, and then by then you've used it well, and then you put it in the bin and then put a new piece on. It doesn't need secondary fixation, which is fantastic, but the problem can be it's expensive. It's not a cheap product, but it works really well. So it's kind of like you pick and choose. The gel sheeting is a bit cheaper, so then if the cost is a problem, then we'll go more gel sheeting. And then the other option, this is more for fingers, is the Silipos finger tubes. I love these. They're so easy to put on. They stay on. They provide compression. I typically get people to wear them at night because I would want them to use their hand at work. Some therapists use it as a bit of if you've got a hypersensitive finger, they'll use that just to kind of cushion it a little bit, but sometimes we don't want that. We want them to use it so they can help desensitize that finger. But I've got some offcuts because I cut them down to fit people's fingers. You can kind of have a feel. They feel funny, but then so someone might say, this is kind of weird, but then once they have it on, they're like, oh, it's actually quite nice. So the Silipos tubes I would use for a few weeks, and then they start again coming towards the end of their days, and then I'll give a new piece, and they'll notice quite a big difference. So anyway, so that was a very quick run through of wounds and edema management and scar management. So it's an area that is so broad. You can talk about this for days, and you still wouldn't cover everything. And everyone has their own way of doing things. But that's what I like about it, is because if one thing doesn't work, there's another option to try. And also, our climate makes such a difference. So, I've spoken to therapists who are in Sydney, and they do things that I would never consider in Cairns, but then I do things that they would never consider either. So it's nice that there's different options. But in terms of getting hold of me, I do have my email. So if you have any questions or want to send us some patients, if you want to have a bit more specialised wound care, you can send to our referrals email as well. But yeah, it's an area that I really enjoy. Any questions?
I've got some questions, so you guys got questions you want to start with? Go first. I thought you might want to talk about what's the difference being a hand therapist? What extra study and experience are you doing, are you undertaking after you've completely finished all your occupational therapy training?
So for hand therapy, so to be able to call yourself a hand therapist, you need to go through an accreditation process. So first of all, you need to either be a physio or an OT, and that's a 4-year uni degree. And then once you have discovered hand therapy and seen how cool it is, you can then go through the Australian Hand Therapy Association for credentialing. So it is a process, there's no time on it. You have to complete, once you start it, you have to complete it within 7 years, just so they know that you're up to scratch. But there are courses that you have to complete. So there's 4 core courses, and then they've got 2 elective courses. So you have to complete that within the 7 years, and then you do a process of supervision. So that's a year-long process where you have a supervisor, they supervise you for a certain amount of hours, and then it's a whole process of really going through your learning and understanding your clinical reasoning and all that type of stuff. And then you need to have a certain amount of hours, which is 3,600 hours of clinical treatment, which is a lot. So if you're working full-time in hand therapy, it's about 3.5 years of solid practice. So it's to make sure that the Australian Hand Therapy Association is happy with the quality of their practitioners. So when a patient goes to see them, they are confident that they know they're getting gold standard treatment, and that they're not going to someone who doesn't have that support, and they're umming and ahhing about, we don't really know. His hands are just so complicated, but it's also for the whole upper limb as well. But yeah, so I'm getting through that process. So it takes time, and it's we do it while working full time as well. So yes, that's the difference between the general practitioner.
And you just touched briefly at the end there on the difference between how we do things in Cairns and how we do things maybe you say Melbourne or Adelaide. Any specifics that you could talk about for doctors or therapists that might have moved from those places up to Cairns? Anything they might experience?
They use this dressing, this semi-occlusive dressing for fingertip injuries I think it's called IV 3000. And first of all, it's kind of like Opsite, but it's a bit thinner and it works a bit differently. But it's to kind of create like a second skin type of environment. So down in Sydney, Melbourne, they love using it. That's what all the therapists talk about down there. And I had never heard of it until I went down there, because we wouldn't keep it because it would just macerate a wound. We'd probably within a few hours.
Well, we keep it in a version of like an Opsite or an oxide island dressing, but we would always use something far more absorbent underneath it.
Definitely. And it wouldn't be, we wouldn't use it for a fingertip injury.
Never use it directly on.
Yeah, exactly. Sometimes the like oxide, like just film dressings, we would use it just to cover. Maybe it's like a small skin lesion if we're doing treatment and we just don't know what it is, we don't get infected. But it would be that's an example that I had really never heard of until I went down. And then during these courses, they would talk to us, like they talked to me. I was from Farm of Queensland, and we had 2 other therapists from Darwin, and we just did things just so differently in terms of managing moisture. Also, the other thing is maybe personality types in terms of our patients. They might be more stoic patients who don't think that their needs to stay closed because they're like, I've had plenty of scratches before, and typically typically our more blue collar workers who they've probably injured themselves quite a bit, but we need to really remind them, no, this is different. Whereas they might down south might have a bit of a different clientele. So
approach.
I think very much we see the increasing swelling because of the humidity and the heat up here. So our vessels will be dilated and more likely to be leaky in the extremity, and so they'll be much more prone to more swelling up here. And so we have to be much more studious about managing it.
And you mentioned adhesions with tendon repairs. And you talked about how wound healing is really important. Do you want to just dive into why wound healing matters in the case of a tendon repair in order to avoid an adhesion?
Yeah, so with tendon repairs, first of all, they're quite complicated. The tendon is very fragile. It's at its strongest point in surgery, and then it gets weaker as time progresses. So with adhesion, what that means is it's like scar tissue is sticking it down, but where you don't want it. So that means then the tendon won't move. So then with our wound care, we can get that scarring that can stick to the tendon as well. So then that is limiting its movement. So if we have a wound that takes 6 to 8 weeks to close on a tendon repair, you're also not able to get as good glide with that tendon too. And so with that tendon, it's just you're not able to rehab it as well. And so, and it's not as comfortable, but then because you need to move it quite a lot, it's hourly exercises, it's just harder to keep it closed as well. So that's just kind of, that's where when I've had complex wounds and it's the tendon repair, so I'm really trying to get it to close as soon as possible. So,
and it's the flexor tendon.
Yes, typically flexor tendons. The extensor tendons can get adhesion a bit easier, but it's more problems with the flexor tendons because they also have, depends where it is. If it's in the zone 2, there's less blood supply, the nutrients isn't as much, so the body creates more adhesion in that area to try and get more nutrients to that spot as well. So we want to try and limit that and just has just better quality healing as well.
And just a couple of things that I think about with the hypergranulation tissue. I like your comment that is a marker of infection. I mean, obviously with the negative pressure dressings, it's not so much, but you're right. I've always been concerned that it was a marker of infection, and then also sometimes I think it's a marker of maybe foreign material, dirt, that sort of stuff in the bottom of what you're dealing with.
Yeah.
So I'm always careful with hypergranulation tissue. And then the other thing I was going to say is that when the dermis is, you know how you say as they get older, the dermis is very thin, it's quite hard for us to get a subcutaneous stitch in. So you know how we have to run that along subcutaneously, and so sometimes we won't be able to use our typical stitch because we just can't get enough purchase. With the suture. So that's sometimes if you see that's why we weren't able to do it technically. Not very often, but it does happen. And then when they're in cast, I often, when they say they're allergic to the cast or they're reacting to the cast, I often try and address it from the perspective of a fungal infection first. So I try and sort of encourage them to think about maybe it might be an infection rather than jumping straight to an allergy. And maybe that's a tropical thing, you know, we have, you know, maybe they get more allergies down south where the skin's all dry and irritable.
More itchy,
Yeah, and up here we probably get a few more fungal infections. So I always try and introduce that idea to them to try and say, do you want to, so maybe a barrier cream might be working to dry out the fungal infection.
Microdosing to help reset the skin surface back to normal. Works really well.
Yep.
But I encourage you, don't ignore anyone really complaining about
No.
because that's a
They will take it off.
Yes.
Yes.
They do take it off.
And they have been known to take them off, but
Of course, yeah. Well, you can understand why.
But you want no one going into a a neuropathic pain situation because no one will listen to them about the cast.
Yes, I agree. You know, that's always the hardest thing, and then it's so hard to reverse, particularly their trust in things.
Exactly. Other thing that just reminded me of a lot of people, some scars can get quite itchy as well, and patients say, "Oh, it means that it's healing," and it's probably because it's dry. It just needs moisturizer. Some scars can be itchy, just sort of like a histamine reaction as well. So if the moisturizer isn't helping, then I know, okay, maybe I should talk to the doctor that it's not as comfortable, but we also then need to address the scar a bit more. So, but I think we want to keep an eye on it.
Is there any questions online? I can see we've got one person online. If they want to raise their hand, they've got your hand if they've got any questions. So thank you very much. That was a really good, nice broad overview, and I really like hearing about all the different types of dressings. When I first moved to Cairns a very long time ago, we did have a talk about dressings, and it was all about moisture. All about maintaining moisture on the wound and keeping the wound moist, and we dutifully covered everything and kept it moist, and it was very challenging, I think.
We still say that, but we want it moist, but the right amount of moist.
Yes, it's that balance.
It's easy
Yeah.
to get there with us. Yeah, it's up here. It's easy.
I can't see who that is.
I can see who that is, but we can't hear. Do you want to ask a question? Hello.
One question?
Yeah, please.
Yeah, thanks first of all for a great presentation. That was really good and concise and simple, and even a silly country GP like me could follow it. So that's really good. Just one question: scar management. With interest, you said about the point about covering silicone for scar treatment. I wondered, Sarah, you might comment as well, does that sort of pertain more to just the hand? Because, I spend quite a lot of time chopping people up with different things on other parts of the body than the hand, and quite often if they're starting to get a bit of hypertrophic scar, we'll use a gel, which doesn't normally go on under any sort of cover, and historically I've found that to be quite effective if the patient actually does put it on, a tiny little bit every night. But should I be asking them to cover it on other parts of the body, or is this a peculiar thing just on the hand?
You can use this on any part of the body. But you might find that if you're using like the gel sheeting, if it's like on the abdomen, it's not going to. You have to use more of like that adhesive type thing. But that's where the silicone tape comes in really handy. I know some of the plastic surgeons like using it for some of their post-op, some of their procedures. This gel, I find the reason we don't really use the gel is because people wash their hands a lot. It just comes off. So I haven't used it very much, but
I think there's a
great
benefit to the actual contact medium that goes with the sheet, or the tape, or the compression that goes with it. So I don't know that the research on the gel or the waxy versions of the silicone is
good.
I think they're abstracting that this is going to be good based on the research from the contact medium, the sheeting, rather than their own version of research that says the liquid is as good. So, but I think it's wherever you're putting wherever you're cutting, keeping the tension of the wound for 6 weeks is my little guideline.
For scars.
So by taping it with like
either longitudinally down the, here's one I prepared earlier, longitudinally down the scar, or crossways all the way to keep the tension off.
Yeah.
Is
That's
really helpful. Yeah.
And we use them a lot for collarbone scars.
Yeah, we get a lot of shoulder, because we do a lot of shoulder surgery, we're getting a lot of wounds that stretch up. And so basically, Grant, I think the Fixamol almost sticks the epidermis to the Fixamol more than it sticks to the dermis. Like it can almost, they can sometimes get a blister from the Fixamol.
Yeah.
I think that just shows you how sticky the Fixamol is. And so generally speaking, I use for Fixamol, or that sort of principle whereby I'm trying to stick the wound together. I do that for about 6 weeks, and then I try not to get tempted by the silicone until after that because of wound dehiscence issues.
That's normal. Yeah, that's fine.
But the silicone can be effective on the pinkness and the raising of the scar for many years after the surgery. So the Caesar wounds, the Caesar wounds and things like that, the ladies quite like that product. But as Mignon says, you almost need the Fixamol to go over the top of the silicone to get the silicone to actually stay where you're trying to put it.
Yeah.
Some of us will react.
I agree with using tape first and then moving on to silicone
Fixamol
if you need.
shearing.
So the stuff I was referring to is called Dermatix gel. It's a tiny little tube, like an eye ointment tube, and it's about $50. People get a real shock when they go to the chemist, but seems to be very effective. I was probably thinking more about faces and things like that.
Yeah, so you can stick the silicone product onto their face, but then they can't move their face.
So
which is challenging.
So in terms of faces, I've used the silicone tape on my face. I had a thing removed, and it first of all hides it quite well. People didn't really take notice of it, but it was just like a little sliver on the face, and so it was just comfortable. Held it well, didn't stretch too much.
Yeah, it's a
Can't
good
see it much
compromise
anymore.
between the two.
Yeah.
So it's very effective for scars that they're not cosmetically happy with. But you're right, the Sicker Care product can be $100 for a sheet. So when they say, gee, that's expensive, I say, well, you can cut off little pieces and use it all over yourself, for all those old scars that you want to get rid of.
But there's nothing magical about that brand.
Very good.
No,
Thank you.
It's not the original brand.
So
Gel-Smart, Gelmate, that we can get hold of is much more.
No, I love it. It's a really terrific product, and not just for hands.
Yeah, all over.
So thank you, Mignon. Thank you very much for speaking with us tonight, and I hope we all got something out of it, and look forward to seeing you at the next one.
Thank you.
Thank you.
Thank you, everyone.